We are live. And then I think for the format, I think what we'll do is instead of putting your questions in the chat, since we have such a large group, would you just put your name in the chat, and then Josanne, Miss Lucas, and I will work hard to call on you in order so that you can provide your question to Holly after she's done presenting. So would you also be sure to mute your mics, especially if you're on your phone, so we won't have any feedback. And Holly, I'm going to turn it over to you.
Okay, well, let's see if I can make my technology work and bring my slides up.
Perfect.
Does that work?
Yes, ma'am.
Oh, wow, it's amazing. Okay, so as Ms. Kelly introduced me, I'm Holly Knaub, and I have been a radiologic technologist for 36 years, I'm sorry to say, but it's been a great career. Also, my sister entered medical imaging and became a nuclear medicine technologist, so it's the force is strong in our family. We've really enjoyed the career. I hope I can at least spark a little bit of interest today in medical imaging. There is a lot of potential. There's a lot of different things that I'll call modalities. And then at the end, we'll also talk about some of the other areas that you can go into, even other than being at the bedside and taking images on patients. So first off, when you're in school to be an imaging technologist, you'll have a lot of patient care classes, and that is a lot of just being able to identify if the patient is in a crisis mode, if we need to get any other kind of support for that patient, and also just how to keep the patients comfortable while you're taking the images. There's a lot of different things we can do to make the patient comfortable, some sponges, towels, blankets, etc. But there are some things we can't do. So during school, you'll learn what things you can do as far as keeping the patient comfortable and what will get in the way of the image so that you have your best image possible and still keeping that patient comfortable and safe. Image production, lots and lots of science behind this. Some engineering behind this, and even a little bit of math behind this. So you have to kind of have a wide acceptance of the different sciences and maths, and also the interactions with patients. So it's pretty well-rounded. And a lot of critical thinking. If you have a patient that can't do what you normally would do for a specific image, you've got to figure out how to do it. Okay, how can I adjust what I do so that I can get the image that the provider needs to be able to treat that patient? So some of the modalities that I'll be talking about today, we'll start off with X-ray. That's what started everything as far as imaging technology. 1895, Wilhelm Röntgen discovered X-rays. He is the one that came up with the 10 properties of X-rays, and they still stand today. They've never been disproven. So X-ray started in 1895. And then computed tomography came along, ultrasound came along, magnetic resonance imaging, nuclear medicine, interventional, and mammography has been perfected over the years. So those are the things we'll be talking about. So basic patient care, like I talked about, they learn how to image critically ill patients. Especially right now, we're really seeing our COVID population that are so very, very ill in the hospital. We have to be able to figure out how are we going to get that machine in the room and adjust these critically ill patients that are intubated, multiple lines, lots of monitors on them, and still be able to get our imaging. You'll know how to identify patient condition change. Like I said, if someone all of a sudden starts being very confused where they weren't when they came in the room, you'll learn how to identify those types of emergent situations. Technologists are not nurses, even though a lot of people think that everybody that works in a hospital is a nurse. We're not. and we have a very different scope of practice. We are going to learn how to take those images, and that's our focus. If we have a patient that begins to decline and we can tell that there is a difference in their condition, we call a nurse. We are not nurses. We do not administer drugs except for our contrast material. And so it's a very different scope of practice. We are focused on getting the image so that the provider can give the diagnosis, and we have our nursing as backup to help us keep our patients safe. So X-ray production. This is a diagram of an X-ray tube, and this is one of the things as an X-ray student you learn right off the bat. So I showed you this slide just because you can kind of see that there's a lot of that engineering type knowledge that we have. We have to know what those anodes are made out of, what the envelope is made out of, because if something goes wrong with the machine, if it's not exposing as it should, we have to be able to critically think the actual machine and figure out, is it something that I have set wrong, or is there something wrong with the machine and I need to move to another room? So you can see the X-ray beam coming out the bottom, and there you learn everything as far as the filament, how the filament works. Essentially, these X-ray tubes are really big, overgrown light bulbs. The X-rays are on the electromagnetic spectrum, so even visible light is on that spectrum. So when you're sitting in a room and you have a light on so that you can see in the room, it's the same type of thing with X-ray. It's just that X-ray is a very high energy and it can penetrate tissue, whereas visible light cannot. It's reflected off. So those are types of things that you learn in X-ray school. So as you're preparing in your high school classes, if you're really interested in going into X-ray or one of the other modalities that I'm going to talk about today, it's a good idea to take maybe some, extra math classes, some extra science classes, maybe delve into engineering just a little bit. It'll give you a little bit more background to be ready for this type of class when you enter X-ray school. This is an actual X-ray tube. And it's, like I said, a big overgrown light bulb. It is encased in glass, and it's a tempered glass. So because it really does create a lot of heat. And that's one of the things that as you're exposing and looking at your images, if something is wrong with how what we call dense on the image is, then we may know that our tube is about to go out. So those are the types of things you learn. You learn how the tube works and what kinds of failures will cause different imaging artifacts. So here's an example of an X-ray room, and you can kind of see that the tube is up above the patient. There is also a box that is right underneath the tube, and we call that our collimator. And we adjust the collimator so that we're only using X-rays on the portion of the body that we want to actually see. And the image there that you can see on the screen where the technologist is working, you can actually see some kidneys that have been highlighted with contrast material. So that's another thing you learn in X-ray school, is how to safely screen these patients to make sure that they don't have kidney disease or any other kind of contraindication to having this contrast material. So the contrast material is usually an iodine based when it's put into the vein in the arm, and it's filtered out through the kidneys. And on this particular image, that's how we're actually looking at the kidneys. And that's kind of what an X-ray looks like, right? That's a Kermit X-ray. All right, so next we're going to get into computed tomography. And computed tomography actually used to be called CAT scan or computed axial tomography. And it has since changed names to just computed tomography because we can take a set of data points and then reconstruct them into any format that we want. So it's not just what we call axial anymore. It can even go into three-dimensional, and I've got some examples of that. So with a CAT scan or a computed tomography scan, inside that gantry where the big hole is, where the patient goes in the middle, is a really big X-ray tube. So not only is it an X-ray tube, it's an X-ray tube on steroids. It really pumps out the radiation. Got a picture of the inside of a CAT scanner. This is somebody was doing some service on this machine. And the whole thing inside there where you see like those fans, that helps cool the tube and the image detectors because they do get very, very hot. And it spins very quickly inside that gantry. And the patient goes in the donut hole, and we take our images while that tube is spinning. Sorry about that. So that's where we get the axial term, is because when the patient is lying on that table and they're going through the gantry, that is an axial image. But then we can take all those data points through the computer and put them in any direction we want to. So on the right-hand side, you can see the pictures of the brain. In the middle, the one in the middle, that is an axial, whereas the one on the bottom is a coronal view. So you can take these data points and reformat them any way you want, and then you can see the three-dimensional image of the actual skull that is also off of those data points. So as you're thinking about going into imaging, CAT scan is very, very fast-paced. These are people that have had major trauma, or maybe we're tracking cancer, but it's very quick. It's in, out, in, out, in, out. So it's one of those that you have to be able to think quickly and be able to identify changes quickly, and also have a very good understanding of computers and how computers work. So this really has a lot of post-processing, so a lot of computer work, as well as that patient care, screening for the IV contrast material, and all those other things I talked about with X-ray. Usually computed tomography techs have been X-ray techs previously and have cross-trained on the job. So what we have is modules that you can get through our professional organization, and you learn those modules, and then you challenge a test, and then you do the clinical like our employees will challenge the test and then do their clinical to be signed off to be registered CT techs. Hopefully that makes sense. For more questions at the end. And then here's a knee, and I put this in here because later on we're going to talk about MRI and the differences. I wanted to kind of show the differences of the imaging between a CT of the knee and an MRI of the knee. So you can see on that bottom right, we can do 3D reconstructions of bone, but you don't see the soft tissues as well. Now that image that's labeled C, you can see some of the tendons that are inside the knee, but if there is a very slight tear, we really can't see it very well on CT, whereas when we get to MRI, we'll be able to see it much better. But on those bottom pictures of the bone, it's called windowing. So there again is using the computer to manipulate the data that has been from the scanner, and we do bone windows versus soft tissue windows. So those numbers B and C are soft tissue windows. We're trying to see the soft tissues. It's the same data that we then, in letter A, image number A, that's a bone window. So you can see the all the cortical, all the imaging is set to bone. It's called windows and levels. It's how many shades of gray and how light or dark those shades of gray are. That's windowing and leveling in CT. So then ultrasound, this is something completely different. This does not use X-rays at all. This is using ultrasound waves. So it's almost like a submarine sonar. You know, when you see the movies from submarines and you hear the ping go out, that's the same idea with ultrasound imaging. The ping is is sent out from what's called a transducer, and that's what these are. And then there is a crystal inside those transducers. It's called a piezoelectric crystal that when the ping or that energy that was sent out from the transducer is bounced off body organs and comes back to that piezoelectric crystal, it creates a shade of gray on the images. So I'm sure most people have seen an ultrasound picture of a baby. And now we even have what's called 4D in ultrasound. So not only can we do three-dimensional imaging like this little fella, we can actually do three-dimensional imaging and watch the baby move. So it's really beneficial for babies that maybe are being diagnosed with a heart defect. We can do three-dimensional imaging of the baby's heart and watch it pump and watch it move. So very, very advanced technology with this also. Ultrasound techs can go straight into an ultrasound school. They do not have to be an X-ray tech first. However, I have noticed that people that have started with X-ray and then gone into ultrasound actually catch on to the ultrasound anatomy and patient care a little bit more quickly. I have staff that have done both, that have gone either straight into ultrasound school, and some that have started as X-ray techs and then cross-trained into ultrasound. Even if you're an X-ray tech first, it is at least another year of school to become an ultrasound tech. If you go straight into ultrasound school, you can find most of the programs are 2 years. X-ray school is also 2 years. And then, as I said, you work for a while, and then some of these other modalities you can cross-train in and not have to go back to school. Not so with ultrasound, you got to go back to school. Here's also a picture of a liver. So one of the things, not only do you have to have very close contact with the patients, you've got to know your anatomy very, very well. All these different shades of gray are showing skin, the liver, vessels on end, and you just have to know how to interpret all of these images. What you see as a technologist is going to greatly influence what the radiologist, then the doctor that reads the images, has to say and gives to the provider for that patient. Hey, MRI. So as it says, magnetic resonance image production is a really, really big magnet. This is an electromagnet, and as you can see, it completely encloses the patient. They're on a table and it slides into the opening, and then they're inside a great big magnetic field. We have 2 of these magnets here at MCR. One of them is called a 1.5 Tesla, and the other one is a 3 Tesla. The 1.5 Tesla is about 20 to 25,000 times the Earth's gravitational pull. So you can imagine the 3 Tesla is over double that. We have what's called the Gauss line that surrounds the actual machine. And at a certain Gauss line, you will actually start to feel that magnetic pull going towards the machine. So with magnetic resonance imaging techs, a lot of their schooling is how to screen patients for safety. If you can imagine with having a 20,000 times the Earth's gravitational pull, if something metallic enters that room, it's going to get sucked into that magnet. It can cause extreme damage. And since these magnets are so strong and they are electromagnets, they produce a lot of heat. So a lot of the blue area and the white area that is surrounding the coil on this picture is filled with helium. And it's very, very cold. So we have to super cool this big magnet. If something metallic gets sucked into the machine and it breaches where that helium is, it will cause what's called a quench, and all of that will escape and burn off the machine and into the room. And outside we have a big vent that goes out the roof. But it's very, very dangerous, and we can cause frostbite if a patient is actually in the scanner when it quenches. So many of the things that we have to screen our patients for, obviously, is metal inside their body. Any kind of implant that they have, even if they have like a screw in their ankle, we need to know about it because we need to know how long it's been there. Depending on what body part we are scanning, if we need to scan their ankle and they don't tell us that there is a screw there, for one thing, it can heat if it hasn't been in there very long and cause a burn. And for another thing, it's going to cause a big black hole on our imaging, and we're not going to get a diagnostic exam. We have to screen for things like eye implants, ear implants. At the very beginning of magnetic resonance imaging investigation, there's a history story, and I wish I could remember the gentleman's name off the top of my head. He was very influential in wanting to see MRI go to production, and he was bankrolling a lot of the investigation and experimentation. And so he wanted to be the first person in an MRI scanner to take a picture of himself. So they put him in the scanner, and when he came out, he was blind. Come to find out, he had eye implants, and he was blinded for life. So that is why we screen and screen and rescreen. We ask the patient 3 times if there is anything that they have inside their body, any surgeries. And some people get a little irritated. They say, well, why do you need to know if I've had my gallbladder out? Well, sometimes when they take a gallbladder out, they put in metal clips. If we're trying to image the abdomen, that clip is going to show as a big black hole. So it may change. Instead of having an MRI, the patient may go to CT or they may go to ultrasound. MRI is another modality that you can cross-train on the job after you've been an X-ray tech for a while. So here's some examples of imaging on MRI. And I put the brain up there to show you the difference between those images that were from the CT. The one on the left looks kind of like a CT image, but the one on the right where it says T2 weighted, it is actually highlighting the fluid that is surrounding the brain and is in the ventricles in the brain without any contrast material. All we did is change the energy level that is in the magnet. So not only is the patient in the magnet, we then are bombarding them with radio waves, very high frequency radio waves. And that's how we get the different imaging with the MRI, even without any IV contrast material at all. This is just done through the magnet and the radio waves that are bombarding the patient. On the right there, you can see the spine. And in between the spinal canal, you can see the actual cord in the spinal canal and the surrounding fluid. You can see the bones there, but you don't see them as well on this image because we're weighting it and we're using specific radio waves to look at that fluid around in the spinal canal to see if any of the discs in the spine are pressing on the spinal canal. You can see it's a little bit like a wave. So this particular image is showing that this patient has some degenerative disc disease, and it is starting to impinge on that spinal canal. So this patient may be having some pain in the legs, maybe some pain in their low back. And so that's why they're having this MRI, is to look at, with that, the weighting for the fluid, we're looking a lot more detail than we can with CT to that spinal canal. And here's what I was talking about with an MRI image of the knee. You can see the soft tissues better. You can also see if the bone has been bruised, because you can see actual bleeding in the bone on an MRI that you may not be able to detect on a CT. So there's very definite different uses between MRI and CT. So, you know, sometimes people will say, well, oh, now that there's MRI, we're not going to need CT anymore. Absolutely not true. They are very, very distinct, and we definitely need both. MRI is a very long exam. Usually it takes about an hour to get all the images done on an MRI, whereas a CT is very fast. We can get everything done in about 15 minutes. So definitely different imaging, definitely different specialties, and we need them both. Okay, nuclear medicine. This is completely different. This does use radiation, but instead of an X-ray tube, which on this picture, it almost looks like there's an X-ray tube in that block portion that says Phillips on there. It almost looks like there's an X-ray tube in there, but there's not. It's actually just a big crystal. So with nuclear medicine, this is the only modality that we can actually test function and not just structure. Everything else up to this point, we can only look at the structure and not how well or how efficiently an organ is functioning. So with nuclear medicine, we inject radioactivity into the patient's body. Sometimes we actually have them ingest it or eat it if we're looking at how quickly their stomach empties. This particular picture here, they're getting ready to inject a radioactive isotope that is attached to a drug that will go to a specific organ. So with these images on the left there, you can see a skeleton. So this was a bone scan. So they inject that radioisotope that is attached to something that goes to bone. Well, what goes to bone? Calcium. So it's some sort of a drug that will be attracted by the bone. That's how we outline the bone in nuclear medicine. For these exams, we're going to look for what's called hotspots. So any kind of increased activity means that there is more activity in the bone in that region. On the very far left, you can see in the shoulders on this patient, they look a little bit hotter than, or darker, big black region, than it does, say, in the knee on this patient. So I would suspect that something is going on with this patient's shoulders. Either they have rheumatoid arthritis or there's some other diseases that can affect the bone that will actually result in an increased uptake or a hot spot on a nuclear medicine scan. So the radioisotope goes to that body organ, and then it is releasing gamma radiation. So there's another point of going into the sciences and learning the different types of radiation. This is gamma radiation, not X-rays. So the gamma radiation is coming out of the patient's body and being hit by, and I'll go back to that other picture, the crystal that is above the patient. So I don't know if anybody has heard of an art form called stippling, but it is literally taking just points and putting like a paper, a pencil lead on a paper multiple times and making kind of an outline. And that's kind of what nuclear medicine does, but with radiation on a crystal. So if you are curious, you can look up stippling, and that's kind of how nuclear medicine images are created. On the right-hand side there, you can see the outline of a liver and the gallbladder, that GB, where it's labeled GB with the arrow, that's a gallbladder that is filled with a radioactive material. It looks very dark because the liver has filtered out some of the bile that the radioisotope is attached to, and it goes into the gallbladder and is held there. Then we can give the patient either a drug or we have them eat something that has a lot of fat in it. And as that gallbladder then releases that radioactivity, we can measure how efficient the gallbladder is. There again, everything else we take a look at the gallbladder. It's very static. It's just looking at the structure of it. This way, we're actually able to measure the function of that gallbladder and how efficiently it contracts and moves all that radioactive bile out. We can also do that for a heart. We can tag a pharmaceutical that goes to the heart muscle, and we can see how efficiently that heart muscle is working. Okay, another thing that is up and coming, and it's getting much more use and it's going into a lot of other areas, is the combination of CT and nuclear medicine, which is called PET, CT PET. So what happens with that is we take a CT, which is this left image, which shows something in the middle of that patient body is the heart, and those are lungs, where it's dark and has like a feathery look to it. That's the lungs. And there's something behind the heart that it's just kind of, what is that? There's something there, but you can't really tell what it is. So then you inject the patient with a radiopharmaceutical, and it is tagged to go to anything that has a very high metabolism. Tumors are different than regular tissue, obviously, because they're cancerous, but cancers and tumors replicate very, very quickly. The cells divide very, very quickly, so they're very active. And so what happens is the radioisotope that is called FDG, and it is actually based on a sugar. So it's a radioactive sugar is injected into the patient, and it will travel to those tumors and it will become very bright. So now we can see that big blob on the back of the heart from CT is now an active tumor when we overlay the nuclear medicine image. So this is called fusing CT and a PET image. Right. Interventional. Just as it sounds, this is going to be something that we are intervening on the patient's behalf. This is another area where you can go to X-ray school and then cross-train on the job with doing the module studies through our governing body to become a registered interventional technologist. We are not doctors either, just to make that clear. We are not actually doing the intervention. We are supporting the doctor that is doing the intervention. So one of the things we can do is, this is contrast material going, you can see underneath the shoulders, up the neck, and into the head. So if you start on that left image, they've got it actually in a positive so that the contrast material is looking white. And where the arrows are showing, especially there on the left, there is a narrowing in that blood vessel going up through the neck into the head. So this is something that we can take into an interventional suite, and through a needle stick in the groin, or right where the hip attaches to the abdomen, and we can take a, well, the doctor will take a coil and go up in there, direct it up through the blood vessels, just through the blood vessels, and put a stent in there to open up that blood vessel so that they get better blood flow up into the head. That image on the right is actually looking downward through the legs. That is the descending aorta and down into the arteries down into the legs. And there again, it's all done on computer, so the radiologist can flip the image to make the contrast either look black or look white, depending on how he can view the anatomy the best. So here's an example of what stents look like and what balloons look like on X-rays as the case is going in interventional. So up above there, you can see where the arrow is showing a narrowed artery. It already has a stent in place. What looks like a Chinese finger trap is actually a very, very fine metal mesh that has already been put into this vessel. So this person is a repeat customer. Then in the middle, you can see where it says balloon. So it looks kind of dark. And what the radiologist has done is just through a vessel, most likely in the groin, has gone up into this vessel. I'm not sure which vessel it is. And there's a type of catheter that you can actually inflate like a balloon. If you think of like the balloon animals that you get at the circus, that's kind of what they look like, just really small. And they go in there, they inflate the balloon, and then they deflate the balloon, take it back out, and check the flow. So that image on the right is showing the improved flow. We have a lot more of that dark contrast material moving through that vessel. The stent is still in place. Those can never be removed. Once you have a stent, you have a stent for life. Okay. And mammography. So mammography is a little bit different because it is a very low energy X-ray. We're not trying to penetrate large body parts. We're just penetrating breast tissue, which is essentially mostly fat. What mammo looks like. This is another specialty that after you've been an X-ray tech for a while, you can go into mammography. You cannot go straight into mammography school. You have to be an X-ray tech first. So mammo, then you learn how to position the woman and men. Men also can get breast cancer to best show and best put in profile the breast tissue so that we can get a good image of all of the tissue. Where that yellow circle is, that actually is very concerning. It's got calcifications. Anything that is very bright on a mammogram is going to be either calcification or very dense tissue, which right below those yellow circles, that is just breast tissue that's very dense. But up inside those yellow circles, there is some calcification that is very bright, and that's very indicative of breast cancer. So that is basically what I had prepared. So I'm going to stop presenting, maybe, and show. There we go. Maybe. Okay, so now I'm back, right?
Yes, you're good.
Okay.
Holly, that was absolutely fascinating. Thank you so much. You're a great teacher.
Well, I went through it pretty fast. Hopefully I remembered to say what I intended to say. Because I didn't have any notes in front of me. So now let's go through questions. What questions do people have?
So Josanne, would you like to manage the chat? And we were going to have the students put their name in the chat and then turn on their camera and their mic and ask Holly the question and then go from there. Okay, Anne, do you want to go ahead and present your question?
Yeah, I was just wondering, like in college, what would you have to major in to go into this like X-ray tech, what you were talking about?
Okay, so there's a few different ways you can do it. There are some universities that offer bachelor degrees in imaging, and when you come out of a 4-year degree, you would have at least 3 modalities that you are registered in. Most of the time, folks will go to a community college and go straight into a specific X-ray program that you'll come out with an associate's degree in radiography. Ultrasound, you can go straight in and have an associate's degree in ultrasonography. And nuclear medicine, you can go straight into a program that you will come out with an associate's degree in nuclear medicine and or PET. Okay, so you have to look for those areas that have those programs offered. There are some here in northern Colorado. Ames Community College in Cheyenne, Laramie County Community College offers programs in ultrasound and X-ray. And now down in the Denver area, there's quite a few programs. You've got to be careful though, because some of the programs that tout being an X-ray tech in say 12 weeks, that is called limited scope, and it's for doctor's office employees that want to be able to take just general X-rays of, say, hands, feet, extremities, chest, abdomen, and that's all they can do, and they can never work in a hospital. So if you truly want to do imaging in a hospital, you've got to come out with an associate's minimum. Bachelors are becoming more common in imaging. And then you must challenge, you must be qualified to challenge the tests, the board exams through ARRT, which is our governing body. It's the American Registry of Radiologic Technologists. Kind of a long-winded answer. Did that give you what you needed?
Yes, thank you.
You bet.
Hey, Becca.
So I was just going to ask you if you had any advice on how to transition from getting a degree in college to finding a job in your field.
Good question. So not only do you go to the classroom and learn the positioning, the patient care, and all those different skills that you need to be an X-ray tech, half of your schooling is in a hospital, and you rotate through different departments so that you're actually doing that hands-on with real patients with a registered technologist by your side. So you actually will have those skills as you graduate. And one of the nice things about having students in a clinical site, which I consider us a clinical site for a couple of the different programs, is that we actually get to see you in action and how you interact with patients and how you interact with the technologists. It essentially becomes a 1 to 2 year interview as well as going to school. So it's a very intensive school. You basically are in school close to 40 hours a week between going to class, doing your homework, and then being in the clinical sites. So we actually get to see you interact, and we kind of pick the cream of the crop.
Okay, cool. Thank you so much.
You bet. Did that answer your question?
Yes, it did.
Okay, great.
Lucy Glenn, you're up next.
Hi, I was wondering why you specifically chose radiology versus like being an actual like doctor or something. Like, why did you make that decision?
Good question. So as I mentioned at the beginning, my sister, and she's much older than I, was a nuclear medicine technologist. So she went from X-ray into nuclear medicine, and she was very successful at it. It's a good living. I mean, you don't get rich, but it's a good living. And there's a lot of other options besides just doing bedside radiography. So one of the reasons I chose to go this direction was, at that point in my life, I was getting married and thinking about having a family, and it was 2 years of school rather than 16 years of school. So there's one thing, is to get into the market sooner, even though I don't make a lot of money. It's comfortable. It's a comfortable living. As you go into the different modalities, there is a different pay structure. So there's other options as far as, do you want to go to CT? You'll get a little bit more money, but it's very intense. You have to find that niche. And that's the nice thing about starting in radiology, is because there's so many different directions you can go. You can find your niche and make a decent living. You can also go into research. There's a lot of X-ray techs that will go into research and look at how to work with engineers to improve the equipment. You can go into sales. There's just a lot of different areas that you can go into, and so there's just a good variety. I happened to choose going into X-ray to begin with, ended up actually going to Ames Community College and teaching for 7 years, and then was offered the position here at MCR as manager. So that it was just kind of a progression that I fell into, but it was a comfortable niche. Does that help?
Yeah, thank you so much.
You bet.
Okay, up next we have Ripley.
I was gonna ask, what would you say your favorite part of working in radiology would be?
My coworkers. I really honestly believe that we have some of the most dedicated and talented people in the United States. We've got a great team. They are very, very dedicated to the patients. They will bend over backwards to make sure that their patient is taken care of and comfortable. I just really enjoy working with other techs. And we have our nurses that are here in the department too. We work very closely with our radiology nurses. They're amazing. So I just really enjoy seeing the dedication of these people and helping support them to be able to meet their obligations to the patient. They're good people, really good people.
Thank you.
Uh-huh.
Okay, and this one is a follow-up question from a student who had to leave. Thea all wanted to know what you like most about your job, but Ripley asked that. She also wanted to know what you least like about your job.
Oh my goodness, what I like least. Well, in my position right now as a manager, I think what I like least is when something does go wrong and I have to coach an employee, or I have to do an investigation of something that went wrong, whether it was intentional or not. That's very difficult. But in some of the other areas, as far as what I think probably a technologist would say that they like the least is the rate of change, because there is a huge rate of change, especially right now with COVID. It seems like every other day, how we are supposed to be treating these COVID patients changes. So I think it's rate of change. So that is one thing about radiology. You got to be ready to learn it one day and apply it the next day, and then wait for the next change for the third day.
Okay, thank you. Nadia Lee, you're up next.
I was just wondering, you kind of covered this a little bit, but what is one of the most stressful situations that you could be in with your career?
Okay, with career. Okay, what comes off the top of my head as far as if I were still doing patient care? When you have a patient that all of a sudden changes for the worst, they stop talking to you, they can no longer focus, and you have to call a code, which means their heart has stopped or they have stopped breathing. That is extremely stressful when you're doing patient care, and that severe change happens. It's hard, and you want what's best for the patient, and you have to be able to keep that chain of thought going to initiate the code, start CPR, make sure they're breathing. So you just have to be able to think through what needs to happen for that patient. So as far as actual patient hands-on care, I would say that is the most stressful thing that I have been through. And then it kind of depends as far as the different areas in radiology. It's going to have different stresses. If you go into sales, obviously you're going to have to meet sales quotas. So that's going to be your stressor, is being able to meet with people and get your equipment in front of those people. That's going to be a different stressor. For management, like for me now, the stressor is meeting with those sales representatives and getting the most appropriate equipment in the facility. Managing people cannot always be easy. And there's always patient complaints. You do the best you can, but sometimes there's patient complaints, and sometimes those are very difficult to deal with. So that just kind of, hopefully that gives you a little idea of the different types of stresses for some of the different career options in radiology.
Thank you so much.
You bet.
Anna Wynn, you're up next.
Okay, so you said that it's really fast paced in like CT scans. I was wondering how many scans on a normal day that they go through.
Put it this way, my 2 CT scanners that are attached to the emergency department. So we do emergency department patients, outpatients, and inpatients that are in the hospital. And we have had days that we have done over 100 patients a day. Most of the time, I bet we're around 60 to 65.
Wow. Okay, thank you.
Uh-huh.
And I have a follow-up question too. Roughly, how often do you need to replace equipment and or service equipment? And then how do you make the decision on which new one to get into the facility?
Okay, that is a loaded question. X-ray machines, just basic X-ray machines, actually can last up to 20 to 25 years if they're well taken care of. We have to have them inspected by a physicist. So that's another area that you can actually go into is medical physics. If you really enjoy physics and you really enjoy the math and the science behind physics, that's another area in radiology that is utilized all the time. We have to have those physicists inspect that equipment so that we meet our state obligation. We have to have a sticker from the state saying that every year that equipment has been inspected. So X-ray tubes they say that they're supposed to last 10 years. However, I have seen them go 20 to 25 years. A CT scanner, I've got one right now that's 14 years old. It's end of life. It's got to be replaced this year. MRI scanners, they say 10 years. I've got one that is 12 years old and it is dying a slow and pitiful death. So we'll be getting a new MRI scanner probably within the next year. Let's see, nuclear medicine cameras also last about 12 years. Ultrasound equipment actually goes out quicker. We'd need to replace those about every 7 to 8 years. Sometimes upgrades can be done and extend the life of equipment. Sometimes it's just the X-ray tube that goes out. We can replace the tube and get a few more years out of the equipment. Other times it's just some of the other mechanical parts that go out. And after a certain time frame, the manufacturers stop making those parts. And that's when they have to start robbing other pieces of equipment to get the parts that we need to keep functioning. That's the point my CT scanner is at now. We're starting to rob other facilities' dead equipment to replace to keep parts going. As far as the part of the question to get new equipment in, okay, there's quite a bit that goes into that decision, and I'll use our CT scanner as an example. So CT gets used a lot from the ED. Our facility is going to try and become a trauma 1 facility, which means we will get the worst of the worst traumas. To that end, I need to have the best of the best scanner. And that means I'm going to have to look at how fast the scanner is, how quickly it will cool the tube so that I can keep going, scan after scan after scan, because I've got to have that heat cooling. So that's one of the things I have to look into. Will it fit in the room? There's only a limited amount of floor space in each one of those suites, so I've got to make sure that the machine's going to fit. Let's see, what else can I say? Our nuclear medicine camera. When we got that one a year ago, we had to look at, for one thing, budget. What kind of exams are we going to be doing? So all of those different things go into what can we afford, what do we need, and what do we need to petition for to be able to meet our needs for our providers. I talked about the trauma situations. Also in CT, we do a lot of hearts, and the longer the scan takes, then you get heart motion and you get a suboptimal scan. You can't work with it because the heart is pumping. So we need a faster scanner so that we can do one sweep and get the whole heart. So those are the types of things that we talk about. We look at what the vendors have out on the market, and then we start asking senior management for a lot of money.
All right, thank you. Thank you so much.
Well, Holly, I just want to thank you for being such a great teacher, being so generous with your time and expertise. The images were amazing. Thank you for walking us through all of those. And we hope that you'll come back for another cafe sometime.
That'd be my pleasure.
Okay, well, thank you so much. And students, if you have any additional or follow-up questions, you can contact Josanne, and she will get those on to Holly via email. And everybody have a safe and wonderful weekend. And Holly, thanks again for all you do every day.
Absolutely. It's my pleasure. Glad to be with you.
Okay, thank you. Bye-bye.
Take care.
Hey, thanks, Holly.
Thank you.
Bye. Thank you.
Ms. Capello, you still on?
Jerome, are you still on?
Yeah, I'm still on. I was wondering if my instructor was still on or not.
Oh, now is that was that helpful?
Uh, yeah. I mean, I am a I'm a for the master's degree program for my teacher licensure.
Mm-hmm.
So I could see where, her presentation style would be helpful for me to get students, maybe involved with finance, because that's my area of study. So I could see where I can do a presentation similar to that to maybe inform students on, what careers they may want to be involved in on the finance side. So
Yeah, and we've found this to be extremely helpful because there's so many different careers out there,
yeah,
and most of us only know the big ones.
yes,
And
yeah,
sometimes you don't know the nuances or the in and out and the daily routine of a particular career.
that's right, that's right. Yeah, I was listening to that and I was thinking, wow, that's something that maybe my daughter could get into. Uh, well, she's in the cosmetology field, and she's doing good, but with the COVID restrictions, everything has just really come to a grinding halt,
Mm-hmm.
So I don't know. I don't know if she'd be interested in being a radiologist, but doing 2 years of school and getting into something like that wouldn't be too bad.
Yeah, exactly. And a
Yeah.
couple of places she mentioned was Ames. Those are, yeah.
Yeah. Ames is where's that?
I believe Ames is in Greeley. I could be wrong about that, but I think Greeley.
Okay. Okay. That's cool. Not too far away.
Mm-mm.
Yeah. Yeah, those are some interesting interesting topics that you brought up though.
Yeah, and for the most part, every speaker panel series, it's a different topic each time.
Oh, I see. So have you had somebody doing a crime scene investigations and all
We
that?
have actually.
Oh, okay.
Yeah.
Right
That
on.
was the second one. Yeah, we had a criminalist
Oh,
talk
wow.
about her career.
Hmm.
And the one thing I love and admire too is that there's no clear path, that you could start off doing different things and eventually make your way to a particular career. It doesn't have to be high school, college, and then straight into that.
Yeah, exactly. Yeah. Yeah. Because I went into the military right after high school because I didn't want to go to college, but when I got into the military, it was almost like college because of course they're gonna, expect you to learn things, expect you to know how to do stuff. So you had to do a lot of studying anyway. And I went in as a firefighter, so I had, firefighting subjects to learn and, be proficient at. So there was, a good deal of study, and of course, if you want to be promoted, you have to study some more. So it was like constant studying. It was like, man, I could have went to college. But it was cool because, in college, of course, your first 4 years, you're not making any money. But other than that, yeah, I could have went to college right away, but I ended up going to college while I was in the military, and it worked out, I just finished my bachelor's as I got out of the military. And then I was like, well, I need to finish my degree and use my GI Bill.
Mm-hmm.
So I was like, well, maybe I want to do some teaching because, in fact, I was already doing some teaching with firefighting, stuff like that. So here I am.
No, I hear you. I went into professional sports right after college.
All right.
And this topic is interesting to me because I've had so many different scans
Yeah.
done.
Yeah. I've had a few of those scans done too. It was interesting in that way too, because I was like, wow, that's exactly what I went through, the MRIs and all that stuff. So.
Mm-hmm. Yeah.
Yep. Yeah. And I was gonna ask more like technical questions, but I started to understand that, this is for like kids that are going into college from high school at this point and looking at different careers, correct? Or the
yeah, because most of them don't quite. I mean, some of them know what they want to do.
Yeah.
But then sometimes you might hear a presentation and realize that, this is actually a little bit more interesting. But what we try to do is to get them exposed to different careers from these professionals who come in to speak to their career. And then the main objective, the absolute main objective of the academy, the Bioscience Career Academy, is to give them some experience and exposure in an internship. So they hear the different presentations, they figure out where they want to get more experience, and then they do an internship in that field.
Oh.
Yeah, and we do have a student right now doing an internship in radiology.
As a high school student?
As a high school student, yeah, they do it their junior, the sum of their junior year.
That's really good, especially when people that are successful in their careers reach back and make themselves available, because she probably doesn't get paid much for doing presentation or whatever. It's all out of the
yeah, and they all want to they all want to give back.
Give back. Yeah,
the support has been overwhelming.
Yeah, that's a great way to give back too. It's just try to reach back to the kids and talk, because that's a lot of times they don't have the confidence to ask certain questions, or they don't know what questions to ask until they get some type of some type of outline of what they might be doing. Like with this is a perfect outline. I mean, she went deep in some of the subjects too, but it was still good because I'm sure some of these students have had some background study on some of this stuff.
Yeah, in some subjects. And speaking of students, let me check in here. Jacob, do you have any questions? Jacob, George, Maya, Alex, and Avril. Avril, you still on? Okay. Well, Jerome, lovely chatting with you. I'm gonna hop off here. I have another meeting.
Okay. Well, thanks for the invite and thanks for the hospitality.
Yeah, anytime. And you could also reach out if you have any additional questions. I don't know if my email
I can
would
give you
show
mine.
up, but I could put it in the
Oh,
chat.
okay.
Josanel at psdschools.org.
Okay, let me see. Oh, I see now. Josanel.
Yeah, Joe's Anna. Josan L. L
Uh-huh.
for Lucas.
PSD. Oh, the last name is Lucas?
Last name's Lucas.
Okay. My last name is King. All right. All right. Josanel.
All right. So see ya. Take care.
Okay. See you. Take care.
Bye.
Bye.